Welcome to Pediatric Case Review. Today we have a comprehensive case-based lecture on hypersensitivity pneumonitis in children. This is an important and often underdiagnosed condition in pediatric respiratory medicine. We will cover the immunological mechanisms, environmental triggers, clinical presentation, examination findings, investigations including imaging and lung function testing, treatment strategies, and long-term complications. 15 carefully designed clinical cases will guide us through every key aspect of this condition. Let us begin. Question 1. Underlying immunological mechanisms. A 14-year-old patient presents to the emergency department with a 3-day history of recurrent fever of 38.5 degrees Celsius, progressive dyspnea, and dry cough. The symptoms began 6 to 8 hours after cleaning the family's pigeon loft. Physical examination reveals tachypnea and bilateral fine inspiratory crackles. The patient appears anxious but alert. Which hypersensitivity reaction types primarily drive the pathophysiology of hypersensitivity pneumonitis? Option A, type 1 and type 2 reactions. Option B, type 2 and type 5 reactions. Option C, type 3 and type 4 reactions. Option D, type 1 and type 5 reactions. The correct answer is option C, type 3 immune complex mediated and type 4 cell mediated delayed reactions. In type 3 hypersensitivity, antigen-antibody complexes deposit in alveolar walls, complement activation triggers inflammation, and neutrophil infiltration occurs in the acute phase, typically within 4 to 8 hours of exposure. In type 4 hypersensitivity, T lymphocyte activation and macrophage recruitment lead to granuloma formation in chronic cases, developing 24 to 72 hours post-exposure. A critical clinical pearl. Both mechanisms can occur simultaneously, which explains the biphasic nature of hypersensitivity pneumonitis symptoms. Question 2. Identifying environmental triggers. A 10-year-old boy develops a persistent cough and mild shortness of breath 4 to 6 hours after helping his father clean their pet parakeet's cage. The symptoms resolve after 24 hours but recur each time he is exposed to the birds. His past medical history is unremarkable. Which organic antigen is most likely responsible for his respiratory symptoms? Option A, Aspergillus fumigatus spores. Option B, avian proteins from bird droppings and feathers. Option C, dust mite allergens. Option D, bacterial endotoxins. The correct answer is option B, avian proteins from bird droppings and feathers. Avian proteins from bird droppings, feathers, and serum represent the most frequent cause of hypersensitivity pneumonitis in children. Fungal spores from household mold and agricultural sources are equally significant triggers. For birds, the specific proteins include pigeon serum proteins and feather dust, with exposure occurring through pet birds and urban pigeon contact. For mold, the key organisms are Aspergillus fumigatus and Penicillium, found in damp homes and agricultural areas. Always take a detailed environmental history in any child with recurrent respiratory symptoms. Question 3. Acute presentation symptoms. A 9-year-old boy presents to the emergency department with sudden onset of flu-like symptoms that began 6 hours after helping his father clean out a dusty basement filled with old bird cages and hay bales. The child was previously healthy with no known allergies. Which clinical finding is most typical of acute hypersensitivity pneumonitis in this scenario? Option A, gradual onset of chronic cough over several weeks. Option B, sudden fever, chills, and dry cough within hours. Option C, wheezing and bronchospasms similar to asthma. Option D, skin rash and eczematous changes on arms. The correct answer is option B, sudden fever, chills, and dry cough within hours. The acute phase of hypersensitivity pneumonitis typically begins 4 to 8 hours after antigen exposure, peaks at 12 to 24 hours, and resolves within 48 to 72 hours if exposure ceases. Key acute symptoms include high fever and rigors often above 38.5 degrees Celsius, non-productive dry cough, dyspnea and chest tightness, malaise and myalgia, and headache and fatigue. An important clinical pearl, these flu-like symptoms frequently lead to misdiagnosis. The key differentiator is always the temporal relationship between symptom onset and antigen exposure. Question 4. Chronic presentation and progression. An 8-year-old girl presents with a 6-month history of progressive symptoms. Her parents report gradual weight loss of 4 kilograms and increasing exercise intolerance. She used to play soccer regularly, but now becomes short of breath after climbing 1 flight of stairs. Physical examination reveals digital clubbing and fine inspiratory crackles at both lung bases. What is the most likely clinical manifestation that distinguishes chronic hypersensitivity pneumonitis from acute forms? Option A, sudden onset of high fever and chills. Option B, progressive pulmonary fibrosis and restrictive lung disease. Option C, immediate wheezing after allergen exposure. Option D, acute pneumonia-like infiltrates on chest X-ray. The correct answer is option B, progressive pulmonary fibrosis and restrictive lung disease. Chronic hypersensitivity pneumonitis develops insidiously over months to years and is distinguished by its irreversible fibrotic changes. Digital clubbing in this child develops due to several mechanisms. First, chronic hypoxemia from persistent low oxygen levels stimulates clubbing development. Second, long-term inflammation releases growth factors that affect nail bed vasculature. Third, chronic respiratory compromise leads to poor growth and development, causing failure to thrive. Unlike acute hypersensitivity pneumonitis, the chronic form progresses slowly and may not be recognized until significant lung damage has occurred. Question 5. Physical examination and auscultation. A 12-year-old child presents with a 6-week history of progressive dyspnea and dry cough. Parents report exposure to pet birds at home. Physical examination reveals tachypnea and mild cyanosis around the lips. You proceed with chest auscultation. Upon auscultating this child with suspected hypersensitivity pneumonitis, which specific breath sound is most characteristic during the mid to late inspiratory phase? Option A, coarse wet crackles throughout inspiration. Option B, fine inspiratory crackles, also called Velcro-like rales. Option C, expiratory wheeze with prolonged phase. Option D, diminished breath sounds bilaterally. The correct answer is option B, fine inspiratory crackles, also described as Velcro-like rales. Fine inspiratory crackles are the hallmark auscultatory finding in hypersensitivity pneumonitis. These dry, high-pitched sounds occur due to inflammatory changes in the alveoli and small airways. They are described as fine, dry crackles heard during inspiration, sometimes with high-pitched squeaks or chirps. They are most prominent at the lung bases initially, may progress to involve entire lung fields, and persist throughout the respiratory cycle in severe cases. This contrasts with the coarse wet crackles of infection and the expiratory wheeze of asthma. Question 6. Systemic physical findings. A 12-year-old girl with chronic hypersensitivity pneumonitis secondary to prolonged exposure to pet birds presents for follow-up. Her parents report worsening exercise tolerance and fatigue over the past 6 months. Physical examination reveals digital clubbing and reduced oxygen saturation, which systemic physical finding would suggest the development of secondary pulmonary hypertension. Option A, hepatosplenomegaly and ascites. Option B, prominent jugular venous distension and peripheral edema. Option C, lymphadenopathy and skin rash. Option D, muscle weakness and joint swelling. The correct answer is option B, prominent jugular venous distension and peripheral edema. In chronic hypersensitivity pneumonitis, progressive pulmonary fibrosis leads to increased pulmonary vascular resistance, resulting in pulmonary hypertension. This manifests as a loud pulmonary component of the second heart sound, right ventricular heave, also called parasternal lift, and eventually signs of right heart strain and failure, including jugular venous distension and peripheral edema. Clinicians must actively look for these cardiovascular signs during follow-up of children with chronic hypersensitivity pneumonitis, as they indicate advanced disease requiring urgent reassessment and escalation of management. Question 7. Laboratory investigations and serology. A 12-year-old boy presents with recurrent episodes of fever, cough, and dyspnea occurring 4 to 6 hours after visiting his grandmother's house, where she keeps multiple pet birds. His symptoms resolve within 24 to 48 hours of leaving the environment. Physical examination reveals bilateral fine crackles and mild tachypnea during symptomatic episodes. Chest X-ray shows subtle bilateral lower lobe infiltrates. The physician orders comprehensive blood work, including serum-specific immunoglobulin G antibodies. What is the clinical significance of finding serum-specific immunoglobulin G antibodies, also called precipitants, in this case? Option A, they confirm active infection and require immediate antibiotic therapy. Option B, they indicate previous or ongoing exposure to specific antigens and support the diagnosis. Option C, they represent normal immune response and have no diagnostic value. Option D, they suggest immunodeficiency and need for immunoglobulin replacement. The correct answer is option B. They indicate previous or ongoing exposure to specific antigens and support the diagnosis. Serum precipitants indicate exposure to antigens but do not necessarily confirm active disease. On initial screening, serum precipitants have a sensitivity of 90% and specificity of 90%. They strongly indicate antigen exposure and support the diagnosis. On subsequent testing, sensitivity drops to 77% and specificity to 80%, and they may decline in chronic cases or after antigen avoidance. Specific antigen panels have a sensitivity of 70% and specificity of 60%. A critical clinical pearl: positive precipitants in asymptomatic children indicate sensitization only, not active disease. Question 8. Imaging investigations. A 12-year-old girl presents with a 6-week history of progressive dyspnea and dry cough. She has been helping her grandmother care for pet budgerigars for the past 3 months. Physical examination reveals bilateral fine inspiratory crackles. A high-resolution computed tomography of the chest is performed to evaluate her respiratory symptoms. Which high-resolution computed tomography finding is most suggestive of subacute hypersensitivity pneumonitis? Option A. Bilateral lower lobe consolidation with air bronchograms. Option B. Ground glass opacities with mosaic attenuation pattern. Option C. Pleural effusions with associated atelectasis. Option D. Hilar lymphadenopathy with peribronchial thickening. The correct answer is option B. Ground glass opacities with mosaic attenuation pattern. The classic high-resolution computed tomography pattern in hypersensitivity pneumonitis consists of 4 key findings. First, centrilobular nodules, small, poorly defined nodules centered around bronchioles. Second, ground glass opacities, hazy increased attenuation preserving bronchial markings. Third, mosaic attenuation, patchy areas of varying lung density on expiratory images. Fourth, air trapping, retention of air in affected lobules during expiration. The combination of centrilobular ground glass nodules plus mosaic attenuation is considered the classic hypersensitivity pneumonitis pattern. This combination in the appropriate clinical context strongly suggests the diagnosis, especially when air trapping is demonstrated. Question 9. Pulmonary function test patterns. A 15-year-old patient with suspected hypersensitivity pneumonitis undergoes comprehensive pulmonary function testing, including spirometry and diffusion capacity measurement. Which pulmonary function test pattern and diffusion capacity result are most consistent with interstitial lung involvement and hypersensitivity pneumonitis? Option A. Normal forced expiratory volume in 1 second to forced vital capacity ratio with increased diffusion capacity of the lung for carbon monoxide. Option B. Decreased forced expiratory volume in 1 second to forced vital capacity ratio with normal diffusion capacity of the lung for carbon monoxide. Option C. Normal forced expiratory volume in 1 second to forced vital capacity ratio with decreased diffusion capacity of the lung for carbon monoxide. Option D. Increased forced expiratory volume in 1 second to forced vital capacity ratio with increased diffusion capacity of the lung for carbon monoxide. The correct answer is option A. Normal or increased forced expiratory volume in 1 second to forced vital capacity ratio with significantly reduced diffusion capacity of the lung for carbon monoxide. Wait, looking carefully at the slide, the correct answer shown is actually A, which describes the restrictive pattern. In hypersensitivity pneumonitis with interstitial involvement, pulmonary function tests show a restrictive pattern: decreased total lung capacity, reduced functional residual capacity, diminished vital capacity, and a normal or increased forced expiratory volume in 1 second to forced vital capacity ratio. The diffusion capacity of the lung for carbon monoxide is significantly reduced, reflecting impaired gas exchange, and its value correlates directly with disease severity. This pattern distinguishes interstitial disease from obstructive conditions like asthma. Question 10. Bronchoalveolar lavage findings. A 12-year-old boy with recurrent respiratory symptoms undergoes diagnostic bronchoscopy. His family keeps pet birds at home, and symptoms worsen after weekends spent cleaning the bird cage. What characteristic finding in the bronchoalveolar lavage fluid supports a diagnosis of hypersensitivity pneumonitis? Option A. Neutrophilia with more than 50% neutrophils. Option B. Eosinophilia with more than 25% eosinophils. Option C. Lymphocytosis with more than 50% lymphocytes. Option D. Decreased total cell count. The correct answer is option C. Lymphocytosis with more than 50% lymphocytes in the bronchoalveolar lavage fluid. Bronchoalveolar lavage in hypersensitivity pneumonitis shows marked lymphocytosis with more than 50% lymphocytes, an inverted cluster of differentiation 4 to cluster of differentiation 8 ratio below 1.0, typically between 0.4 and 0.8. and a predominance of cluster of differentiation 8 positive T lymphocytes reflecting the chronic inflammatory response. This pattern is diagnostically important because it helps differentiate hypersensitivity pneumonitis from sarcoidosis, with a cluster of differentiation 4 to cluster of differentiation 8 ratio is greater than 3.5. A ratio below 1.0 supports hypersensitivity pneumonitis diagnosis. Question 11. Primary management strategy. A 10-year-old girl presents with a 3-month history of progressive dyspnea and dry cough. High-resolution computed tomography shows ground glass opacities and centrilobular nodules. Serum precipitants are positive for pigeon antigens. The family keeps pet birds at home. What is the single most important step in the management of this child to prevent disease progression? Option A. Immediate high-dose oral corticosteroids. Option B. Complete removal of birds from the home environment. Option C. Bronchodilator therapy with inhaled beta-2 agonists. Option D. Prophylactic antibiotic treatment. The correct answer is option B. Complete removal of birds from the home environment. Complete antigen avoidance is the cornerstone of hypersensitivity pneumonitis management. This is critical for several reasons. Continued exposure leads to progressive fibrosis. Even minimal exposure can trigger symptoms. Environmental remediation is often more effective than medications, and early intervention prevents irreversible lung damage. The home and school environment checklist includes removing birds and bird-related materials, addressing moisture problems and mold growth, replacing contaminated bedding and furniture, improving ventilation systems, and performing regular heating, ventilation, and air conditioning filter changes. School assessment should cover classroom air quality, water damage, and animal exposure in science labs. Question 12. Pharmacological treatment options. A 9-year-old boy with known bird exposure presents to the emergency department with severe respiratory distress. He has been experiencing progressive dyspnea, dry cough, and chest tightness over the past 48 hours. Physical examination reveals tachypnea, bilateral inspiratory crackles, and oxygen saturation of 88% on room air. Chest X-ray shows bilateral pulmonary infiltrates consistent with acute hypersensitivity pneumonitis. Which pharmacological intervention is considered the first-line therapy for symptom relief in this acute presentation? Option A. High-dose inhaled bronchodilators with albuterol nebulization. Option B. Oral prednisolone 1 to 2 mg per kilogram per day for 2 to 4 weeks. Option C. Intravenous antibiotics with ceftriaxone and azithromycin. Option D. Inhaled corticosteroids with fluticasone propionate. The correct answer is option D. Oral prednisolone at 1 to 2 mg per kilogram per day. Wait, reviewing the slide carefully, the correct answer shown is D, referring to oral prednisone protocol. The oral prednisone protocol for pediatric hypersensitivity pneumonitis includes an initial dose of 1 to 2 mg per kilogram per day with a maximum of 60 mg daily. The duration of high-dose treatment is 4 to 6 weeks, followed by gradual tapering over 3 to 4 months. The physician must monitor for side effects and disease progression throughout this period. In severe cases, pulse corticosteroid therapy should be considered. A key point: early intervention with corticosteroids can prevent irreversible fibrotic changes in pediatric hypersensitivity pneumonitis. Question 13. Long-term complications. A 10-year-old girl has been experiencing recurrent episodes of cough, shortness of breath, and fatigue over the past 2 years. Her parents initially attributed these symptoms to frequent colds. The family keeps pet birds at home, and despite multiple medical visits, the connection between her symptoms and bird exposure has not been recognized. She continues to be exposed to avian antigens daily. If hypersensitivity pneumonitis remains undiagnosed and the child is repeatedly exposed to the antigen, what is the most serious long-term sequela? Option A. Recurrent pneumonia episodes. Option B. Chronic asthma development. Option C. Irreversible pulmonary fibrosis. Option D. Allergic rhinitis progression. The correct answer is option C. Irreversible pulmonary fibrosis. This is the end-stage complication of chronic hypersensitivity pneumonitis. In terms of progressive fibrotic changes, persistent inflammation leads to collagen deposition. Alveolar architecture becomes permanently distorted. Normal gas exchange surfaces are replaced by scar tissue, and a honeycombing pattern develops in severe cases on imaging. The functional consequences include irreversible restrictive lung disease, progressive exercise intolerance, chronic hypoxemia in advanced cases, and poor long-term prognosis without intervention. The critical point cannot be overstated. Early intervention is essential to prevent this irreversible stage. which is why every physician must consider hypersensitivity pneumonitis in children with unexplained respiratory symptoms. Question 14. Differential diagnosis. A 16-year-old previously healthy teenager presents to the emergency department with a 3-day history of progressive dyspnea, dry cough, and fatigue. 2 weeks ago, she started working part-time at a local pet shop that specializes in exotic birds. Her vital signs show mild tachypnea and low-grade fever. Chest examination reveals bilateral fine crackles. Which clinical feature would most help distinguish hypersensitivity pneumonitis from acute viral pneumonia in this patient? Option A. Presence of low-grade fever. Option B. Bilateral fine crackles on auscultation. Option C. Temporal relationship to bird exposure. Option D. Progressive dyspnea over 3 days. The correct answer is option C. Temporal relationship to bird exposure. Hypersensitivity pneumonitis and infectious pneumonia can present similarly, making the exposure history the most powerful differentiator. Regarding onset pattern, hypersensitivity pneumonitis symptoms begin hours after exposure and improve away from the trigger, while infectious pneumonia progresses gradually over days. Regarding fever pattern, hypersensitivity pneumonitis shows low-grade fever coinciding with exposure episodes, while infectious pneumonia causes high persistent fever until treatment. Regarding laboratory findings, hypersensitivity pneumonitis shows normal white blood cell count, elevated precipitants, and lymphocytosis in bronchoalveolar lavage, while infectious pneumonia shows elevated white blood cells with neutrophilia and positive cultures. Remember, hypersensitivity pneumonitis shows a clear temporal relationship. Symptoms improve away from the trigger and return on re-exposure. Question 15. Diagnostic criteria and scoring. A 12-year-old girl presents with a 6-month history of progressive dyspnea and dry cough. Her family recently moved to a rural area with an old farmhouse. High-resolution computed tomography shows ground glass opacities and centrilobular nodules. Pulmonary function tests reveal a restrictive pattern with reduced diffusion capacity of the lung for carbon monoxide. According to current pediatric guidelines, which combination of factors is required for a definitive diagnosis of hypersensitivity pneumonitis without a lung biopsy? Option A. Environmental exposure plus compatible symptoms plus positive serum precipitants. Option B. Compatible imaging plus restrictive pulmonary function tests plus bronchoalveolar lavage lymphocytosis above 50%. Option C. Environmental exposure plus compatible imaging plus restrictive pulmonary function tests plus improvement with antigen avoidance. Option D. Positive precipitants plus compatible symptoms plus normal chest X-ray. The correct answer is option C. Environmental exposure plus compatible imaging plus restrictive pulmonary function tests plus improvement with antigen avoidance. The integrated diagnostic approach for hypersensitivity pneumonitis requires combining multiple elements. Clinical suspicion begins with respiratory symptoms and known exposure. A detailed history must document environmental exposure and the timing of symptom onset. Physical examination identifies auscultation findings and signs of respiratory distress. Laboratory studies include serum precipitants and inflammatory markers. Imaging studies look for characteristic high-resolution computed tomography patterns. Specialized testing includes pulmonary function tests and bronchoalveolar lavage when needed. Remember, no single test is diagnostic. Integration of multiple findings is essential. We would like to invite you to join our exclusive community, Pediatric Case Review, on Patreon. This community is designed specifically for pediatric physicians and trainees who want to take their learning to the next level. As a member, you will get access to all videos organized neatly by medical system, so you can find exactly what you need in one place. All presentations used in the videos are also available as high-quality images, allowing you to read through the cases and practice all questions at your own pace. You can also practice with comprehensive question banks. For full details on how to subscribe, simply comment below on this post, and we will message you directly with all the information you need. And with that, we have reached the end of today's lecture on hypersensitivity pneumonitis in children. Let us quickly review the 5 key takeaways from this session. First, early recognition requires a high index of suspicion, especially in children with recurrent respiratory symptoms. Second, environmental history is crucial. Always ask about bird exposure, mold, and occupational or home triggers. Third, high-resolution computed tomography and bronchoalveolar lavage provide the most definitive diagnostic clues. Fourth, environmental remediation and complete antigen avoidance are the cornerstone of treatment. Fifth, early intervention prevents irreversible pulmonary fibrosis. If you found this lecture helpful, Please follow the Pediatric Case Review channel for more comprehensive case-based presentations covering all pediatric systems. If you have any questions or suggestions for future topics, drop them in the comments below. We read and respond to everyone.